All right, if you're a trainee managing patients with reflux, this one's for you. We're about to do a deep dive into the 2022 ACG guidelines on Barrett's esophagus. And look, this isn't just a boring review, this is your high-yield playbook for the absolute latest in diagnosis, surveillance, and treatment. So let's get right into it. So first off, why does this matter so much? Well, let's just start with the stakes. For patients who actually develop esophageal cancer and show up with symptoms, the 5-year survival rate is less than 20%. I mean, that is a brutal prognosis. And that's exactly why our entire focus is on catching it before it gets to that point. And that means focusing on this, Barrett's esophagus. It's the only precursor lesion we know of for this type of cancer. You can think of it as a defense mechanism gone wrong. The esophagus gets so damaged from chronic acid reflux that it literally changes its own cell type to try and protect itself. But that change, that intestinal metaplasia, well, that's what sets a patient on the potential path to cancer. So here's how we're going to break it all down. We're just going to follow the logical path you take with any patient. First, how do we actually make the diagnosis? Then, who should we even be screening in the first place? After that, what's our strategy for watching them over time? And finally, what do we do when we find something concerning? Okay, let's dive into section 1, the fundamentals. What exactly are we looking for, and how do we confirm it? Getting this part right from the very beginning is absolutely crucial. So this is probably the first most critical point from the new guidelines. Through the endoscope, you might see tissue that looks pink and velvety, and you're thinking, this is Barrett's. But the ACG is really clear on this. For an official diagnosis, the biopsy has to show intestinal metaplasia. You need to see those classic goblet cells under the microscope. Without them, it doesn't count. And here's the other part of that diagnostic puzzle, a simple rule to remember for your practice. The segment you're looking at has to be at least 1 centimeter long. If it's anything less than that, what we often just call an irregular Z-line, it doesn't meet the criteria. The cancer risk is so incredibly low that the guidelines say we shouldn't even be routinely biopsying it. So let's just walk through the pathway. It's really straightforward. Step 1, you see a salmon-colored segment that's at least 1 centimeter long. Step 2, you take plenty of biopsies. The recommendation is at least 8, because you don't want to have a sampling error. Step 3, your pathologist confirms that intestinal metaplasia is there. And then, the final absolutely critical step, if they see any dysplasia at all, it must be confirmed by a second, expert GI pathologist. And we pulled this quote directly from the guideline because this is a strong recommendation. It's not optional. There's a ton of inter-observer variability among pathologists when it comes to grading dysplasia, especially low grade. So getting that second opinion from an expert isn't just a suggestion, it's the standard of care. It's how you avoid overtreating or, even worse, undertreating your patient. Okay, so now we know exactly what we're looking for. The next obvious question is, who are we looking in, right? We can't just scoop every single person with heartburn. So let's talk about the screening criteria. This is the million-dollar question you're going to get in clinic all the time. A patient comes in, they've had reflux for years. Do they automatically get an endoscopy? Well, according to the guidelines, the answer is a pretty clear no. We need to be smarter about it. We have to stratify their risk. And here is exactly how we do it. It is not enough to just have chronic GERD. To even consider a screening endoscopy, the guidelines suggest that patients need to have their reflux symptoms plus at least 3 of these other risk factors. So you just run through the checklist in your head. Are they male, over 50, white, a smoker? Do they have central obesity or a family history? The more of those boxes they check, the stronger the case for screening becomes. And this chart just shows you exactly why that checklist is so important. Look at this. The prevalence of Barrett's in patients who only have GERD is pretty low, just over 2%. But then you add in 1 or more of those other risk factors, and bam, it jumps all the way to over 12%. It's a huge difference. This is how we find the needle in the haystack. All right, so let's say you've done the screening and you've found a patient with Barrett's. So, now what? Now we shift into surveillance mode. And this is where the new guidelines have really updated our thinking, moving us toward an approach that's much more tailored to the individual patient's risk. So for a patient with non-dysplastic Barrett's, it really all boils down to 2 simple things. How long is the Barrett's segment? And of course, is there any displacement? These 2 factors are going to dictate your entire surveillance plan. Now, this highlights one of the biggest, most practice-changing updates in the whole guideline. For our patients with non-dysplastic, short segment Barrett's, that's anything less than 3 centimeters, we can now extend that surveillance interval all the way out to 5 years. I mean, think about what that really means. It's fewer procedures for our lowest risk patients. That lowers cost, it reduces their burden, and it minimizes procedural risks. It's a really smart move. Now, for the higher risk, long segment cases, so 3 centimeters or more, we're still sticking with that 3-year interval. And here's something you have to burn into your memory for boards and for practice. The Seattle protocol is still the gold standard for how we do surveillance biopsies. That means taking 4-quadrant biopsies, north, south, east, west, for every 2 centimeters of the Barrett segment. You have to be systematic about it because that's how you minimize the risk of missing a tiny hidden area of dysplasia. Okay, on to our final section, and you could argue it's the most important one. What happens when our surveillance actually finds dysplasia? This is that critical moment where we stop just watching and we start acting. We're going to climb the treatment ladder. And the guideline is very direct about this. For any confirmed dysplasia, and that confirmation by a second pathologist is key, whether it's low-grade or high-grade, the standard of care is now endoscopic eradication therapy, or EET. The goal is no longer just to watch it, the goal is to get rid of it. And this comparison just perfectly illustrates why EET is such a game changer. I mean, it really wasn't that long ago that finding high-grade dysplasia meant your patient was facing an esophagectomy, a massive, life-altering operation. But now, with EET, we can accomplish the same thing through an endoscope, with just a fraction of the risk and mortality. It's a revolution in care. The data for treating low-grade dysplasia is just as stunning. If you just watch LGD, the risk of it progressing to cancer is actually pretty high. I mean, it can be over 26%. But with endoscopic therapy, look at that drop. That risk plummets to just 1.5%. This is exactly why the guidelines now push us so hard toward treating, not just watching, confirmed LGD. Okay, so let's boil this all down to the 4 key high-yield takeaways you need to know. Number 1, diagnosis requires 2 things: a segment at least 1 centimeter long and confirmed intestinal metaplasia. 2, we only screen patients with chronic GERD if they have 3 or more other key risk factors. 3, surveillance is now risk stratified by length. Remember that new 5-year interval? And 4, for any confirmed dysplasia, EET is the undisputed standard of care. And we'll just leave you with this final thought to chew on. We've made these incredible leaps, going from huge surgeries to elegant endoscopic therapies. So what's the next frontier? Well, it might be even less invasive. With the rise of AI and advanced biomarkers, could we one day predict a patient's risk of progression with just a simple blood test or even a breath sample? Could we make our care even more personalized? That's the exciting future we're heading towards in managing Barrett's esophagus.